Labor News Conference. Welcome to another edition of Labor News Conference, a public affairs program brought to you by the AFL-CIO. Labor News Conference brings together leading AFL-CIO representatives and ranking members of the press. Today's guest is Bert Seidman, director of the AFL-CIO's Department of Social Security. The recent AFL-CIO convention renewed the Federation's commitment to enactment of the Kennedy-Griffiths National Health Security Bill and directed action to muster and coordinate stepped-up citizen activity toward this end. Here to question Mr. Seidman about the status of the long-pending national health security measure are Judith Randall of the Washington Star-News and Frank Swoboda of Business Week magazine. Frank Harden speaking. And now, Ms. Randall, I believe you have the first question.
Mr. Seidman, with the country in such turmoil about Watergate, about the Cox dismissal, about the Mideast, about inflation, and so many other things, what indications, if any, have you that the public is really genuinely concerned at this moment about doing something about a national health insurance program?
Ms. Randall, it's of course true that there are many other items, very important items, that are making the headlines these days, and that by and large, health questions are not on the front pages of the newspapers, although even this occurs occasionally. But I think that there are quite a number of indications that the question of health and improving the health care of the American people is in the minds of a good many people, both around the country and members of Congress. One indication of it is, for example, that one of the important committees of the Congress, the Senate Finance Committee, is apparently considering that very question today. In our own field, our convention has just adopted a number of resolutions in the health area because we in the labor movement consider this a very important question. All around the country, what are called health security action coalitions, which are concerned with the enactment of the Kennedy-Griffiths Health Security Bill, are being organized in states all across the country. So that while I don't expect national health insurance to take over tomorrow in terms of the headlines from the Middle East question or the Watergate affair, I do think it continues to be a matter of very great concern to the American people and their legislators.
Mr. Seidman, at the convention, the delegates approved a resolution in which they came out in the first official labor opposition to the long Ribicoff health insurance bill and re-endorsed, I guess you'd call it, the Griffin-Kennedy bill. What are the differences, the major differences between these two bills?
Well, the Kennedy-Griffiths bill, which has been introduced by Senator Kennedy in the Senate and Congresswoman Griffiths in the House of Representatives, and with a large number of co-sponsors, this is a bill which would provide comprehensive, across-the-board medical care to every American, man, woman, or child. It would be based on the social insurance principle in terms of the way in which it would be financed. It would provide care in the doctor's office, physician services, and physician services in the hospital as well, hospitalization, prescription drugs, dental care for children, mental health care, and so on. It would provide comprehensive health services. It would also be aimed at improving the organization and the delivery and the quality of health care. This long Ribicoff so-called catastrophic health insurance bill has three parts to it. One part of it would provide for hospitalization and physician services, but only after an individual had somehow been able to finance, through insurance or some other way, $2,000 of physician services and 60 days of hospitalization. And lots of people in this country can't afford to meet that cost. It has a couple of other features. The most desirable one, actually, is one which would provide for some improvements in the present Medicaid program for poor people. But even that part of the program would be very inadequate. And you contrast that with the comprehensive approach of the Kennedy-Griffiths bill.
Mr. Seidman, I don't recall the exact figures, but I know that the estimated cost in terms of amounts of public funds to be used is much, much greater in the Kennedy proposal than it is in the Long-Ribicoff proposal. How do you plan to counter this argument at a time when the country is very concerned about inflation, increasing taxes, and so on?
I think we have to look, Ms. Randall, at the total cost of health care and not just the question of how much money goes into the budget of the federal government. In terms of the total cost of health care, I have no doubt that the cost to the American people of obtaining the comprehensive health care that the Health Security Bill provides would be far less than if we were to enact the Long-Ribicoff comprehensive catastrophic health insurance bill. I say this for this reason, that the Griffiths-Kennedy bill, the Health Security Bill, puts its emphasis on providing preventive services, early diagnostic services, which will keep people from having serious illnesses, which will keep people out of the hospital, which will keep people from needing the most expensive kinds of medical care. On the other hand, the Long-Ribicoff bill would not provide anything at all for the preventive and early diagnostic services. That is what people would have to finance themselves. It wouldn't begin to provide care until you got to the more expensive kinds of care that people need after they've spent $2,000 and after they've been in the hospital for 60 days. So all the emphasis would be on financing the most expensive kinds of care, and we would tend to put our money into that, and the total cost of medical care would therefore be much greater.
Would this in turn tend to inflate medical costs the more? Be a sort of...
Yes, it would definitely inflate the medical costs the more because it would put the emphasis on financing the most expensive kinds of medical care and not providing financing for the less expensive kinds of medical care. It would also have a human cost because people who wouldn't get this care in terms of early diagnosis and early treatment contract the more harmful diseases, the kind that puts the greatest burden on them, and there'd be more serious disease and more deaths.
Mr. Seidman, has the Nixon administration come up with a bill or a proposal of its own?
The Nixon administration had a proposal in the last Congress. It has not introduced a proposal in this Congress. There are rumors that the Department of HEW has sent a proposal up to the White House, but it has not yet come out officially. In any case, if it's anything like the bill that they had in the last Congress, it too would be very inadequate in terms of the way in which it would provide care and the way in which it would finance care.
Didn't it also center on catastrophic costs rather than on comprehensive care?
It did. It also depends entirely on private insurance, and the experience with private insurance has shown that it results in the escalation of medical care costs and no concern whatsoever with the quality and the efficiency of medical care.
In that connection, Mr. Seidman, what has happened to the cost of private insurance and indeed to medical costs as a whole during the period where we've had price controls of one form or another?
There has been some moderation of the costs of physician services and hospitalization during this period. That is, the rate of increase has declined somewhat from the very marked increases that were occurring until this time. However, during the past 2 or 3 months, there have been signs again of an upward slant in the costs of medical care. I have every reason to think that if the controls were taken off, that we would see again a very sharp increase in medical costs.
Well, one of the major cost problems has been the basic shortage of medical professionals and facilities. Would either bill address itself to this?
Well, in the first place, our problem has been, in part, a shortage of some types of medical personnel. For example, family doctors, doctors providing what's called primary medical care as compared with the specialists, and doctors serving people of low income, whether they be in rural areas or in the ghettos of our big cities. Our problem has been more of a problem of distribution rather than the overall numbers of doctors and other medical personnel. But the Long Ribicoff bill, for example, would do nothing whatsoever about this. The Kennedy Griffiths Health Security Bill has specific provisions which are aimed at encouraging the development of primary physicians and also encouraging doctors to go into the areas where there are very few doctors today, that is the rural areas and the low-income areas of our large metropolitan areas.
But as I understood it, the convention passed a resolution urging the lifting of all controls. Aren't you sort of contradicting yourself when you're suggesting that if the controls are taken off where health insurance is concerned, we're going to see a marked rise in costs?
The convention did adopt a resolution calling for the lifting of all controls. We think that as long as the controls have not been lifted, particularly on the wages of workers, that they certainly ought to continue in areas where there has been a tendency to very rapid increases in prices, as in the healthcare field. I'm simply saying that unless we get something like the Kennedy Griffiths bill, which has a built-in cost controls, that when we remove cost controls from the medical care sector, and maybe even if we don't, we'll see a sharp escalation of medical costs.
Mr. Seidman, realistically, the Democrats in Congress have been rather effectively held at bay by this administration when it comes to spending money. Do you think there's any real sentiment for them to get into this kind of a spending proposal for either the Long Ribicoff or Kennedy Griffiths at this time?
Frankly, Mr. Swoboda, I don't know whether the Congress is going to pass health insurance legislation, that is this session of the Congress, or not. I think it's quite possible that they will not. One thing that we do feel very strongly is that it's very important to increase the representation of progressives in both parties in the next Congress, in the elections of 1974, so that we will have the kind of Congress that will enact the legislation like the Kennedy Griffiths bill, and that it will be a veto-proof Congress. In other words, that if the president vetoes legislation of that kind, that the Congress will override the veto.
Well, this brings us back to your grassroots efforts in support of the health care bill, the Kennedy Griffiths bill. I understand there was a resolution passed at the convention urging this type of a campaign. How would that work?
We are supporting an organization called the Committee for National Health Insurance, which in turn is setting up local groups called Health Security Action Coalitions in states all across the country. These include people from the labor movement, other people in the community from churches, civic groups, minority groups, and others who are concerned with the improvement of health care and specifically are interested in assuring the enactment of the health security bill. These have been organized now, I believe, in 22 states, with some important states like California and Indiana, I believe, where the coalitions are in the process of being organized. They are for the purpose of educating their own communities about health needs and how the health security bill can meet their health needs, as well as securing the maximum support for the program in the Congress. They have held meetings They have helped some of the congressmen to hold hearings, for example, Congresswoman Barbara Jordan in Texas. They have obtained endorsement from prominent figures, for example, Congressman Tim McCall, Governor Tim McCall of the state of Oregon is the honorary chairman of the Oregon Health Security Action Council. He happens to be a Republican. They are carrying on various activities for developing support for the health security bill.
One of the things, or one of the criticisms that's been made of Medicare, which in a sense is the forerunner of this whole idea, is that it has poured money into the pockets of doctors and hospitals and clinics and so on and so forth, but that the elderly, the beneficiaries, are paying more for their medical care than they did before the program started. What kind of controls do you think that the Kennedy-Griffiths proposal would have built into it that could prevent this kind of thing from happening?
Well, the Medicare program is an open-ended program. That is, there are really virtually no controls on the costs of the doctors and the hospitals in the very terms in which the Medicare program was set up. The people who worked for the enactment of Medicare knew that this was true. They felt that even though that had this defect, it was better than no program at all. The Kennedy-Griffiths bill has an entirely different approach. It provides for a national budget for health care, and every health provider, hospitals, nursing homes, and other institutions would be expected to set up their own budgets. Therefore, there would be a known amount of money for medical care. In addition to that, it would contain built-in provisions to improve the efficiency of medical care, thereby reducing the cost of medical care. But it would not be possible, it wouldn't be an open-ended program in which you would never know what the costs would be. From one year to the next, you'd know that the amount of money that would be available for medical care would be the amount that had been budgeted in advance.
How about individual doctor fees? Would that be set by law?
There would be negotiation between the Health Security Board, which would administer the program, and the doctors' organizations for the establishment of fee schedules, the kind of fee schedules, for example, that apply in some of the Medicaid programs, as for example in California. And so this would also help to keep down the costs. The hospitals would be, as I said, be expected to budget prospectively. That is, they would have to budget in advance as to what their costs would be. And this would be the amount that they would receive to provide their services, so that you would have a control on the total costs of medical care through all of these various methods.
How about research? After all, one of the things that ultimately makes medical care cheaper and more efficient is a new treatment, like a vaccine which prevents polio or whatever. Would a portion of the budget be set aside for research?
There would be, within a few years after the program started, 5% of the total amount of money set aside under the program for a health security resources program, which would provide the manpower and the facilities and would also help new innovative types of programs and other things which would improve the quality and would help to keep down the costs of medical care.
Thank you. Today's Labor News Conference guest was Bert Seidman, director of the AFL-CIO's Department of Social Security. Representing the press were Frank Swoboda of Business Week magazine and Judith Randall of the Washington Star-News. Frank Harden speaking, inviting you to listen again next week. Labor News Conference is a public affairs production of the AFL-CIO, produced in cooperation with the Mutual Broadcasting System.